let us discuss about let us discuss about psoriasis. Psoriasis. Psoriasis, it is a chronic inflammatory condition. It is a chronic inflammatory condition. Let us see what exactly happens in psoriasis, what causes psoriasis, what is the mechanism of psoriasis. In a normal person, when there is injury or when there is infection, what happens? Inflammation will take place, right? This inflammation will take place when there is injury or when there is infection or when there is invasion by external microorganisms. This inflammation will rescue from injury, right? Will rescue us from injury or infection, and then uh, after killing those microbes or rescuing us from injuries, this inflammation will subside, right? After recovery, this inflammation will subside. But in psoriasis patient, this inflammation will not subside. Okay, inflammation will not subside even after rescue from injury or inflammation will not subside. This inflammation will result in psoriasis. So this especially happens in skin. Okay, when there is trauma to uh, trauma to skin, or when there is infection of skin, this inflammation will start happening, and this inflammation will not subside even after killing the microorganisms. So this inflammation will itself causes injury to skin. So see what how it happens. So this is skin, right? When there is injury, inflammation will happen. This inflammation will result in um, pro- will result in appearance of neutrophils, all cytokines, all these things will be released as part of inflammation, right? So in here what happens is, after in the process of inflammation, keratinocytes, which are the cells of epidermis, these keratinocytes will proliferate. Okay, keratinocytes, which are the cells of epidermis, will proliferate. Okay, proliferation of keratinocytes will take place. These newly formed keratinocytes, these are immature cells, and they do not adhere to each other perfectly. Okay, adherence will not be to each other, will not be good, or will not be perfect, we can say. They do not adhere to each other perfectly. That means they 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 will not adhere to each other, so that it results in separation of cells, right? This is called acantholysis. And one more is, these keratinocytes, they produce excess keratin. They produce excess keratin. So all these things happens in psoriasis. So as they are not adherent to each other, it results in scale formation. As they are not adherent to each other well, so it results in scale formation. See, as it is inflammatory condition, so there will be erythema. So as I told you, as the cells are not adherent to each other well, so it results in scaling. These scales are silvery white in color. Okay, they are silvery white in color. This especially these lesions will be present on external surfaces. Okay, the lesions that we see in psoriasis are erythematous plaques. Erythematous plaques. These plaques will be covered by silvery white scales. Okay, these erythematous plaques will be covered by silvery white scales. These are present on external surfaces, and they can also be present on scalp, palms, soles as well. Okay, this is the basic mechanism how psoriasis will result. Then we'll start the definition. The definition of the disease is: it is a chronic inflammatory condition with multiple immunological, genetic, and environmental defects causing erythematous plaques with silvery white scaling. So, as I told you, it is a chronic inflammatory condition, right? So, in this disorder, there is involvement of environmental factors, genetic factors, genetic factors, and immunological factors as well, because it is there is some defect in inflammation, right? So we can there is necessarily there will be defects in immunology. Okay, all these things results in erythematous plaques. Erythematous plaques which are covered by silvery white scales. Okay, this is about the definition. Then we will see the various types of psoriasis. Before going to types, there are certain predisposing factors to this disease. Predisposing factors. The factors are HLA-CW6. HLA-CW6. This predisposed to juvenile psoriasis. It predisposed to juvenile psoriasis. Okay, HLA-CW6. It's predisposes to juvenile psoriasis, and one more is HLA-B27. It predisposes to psoriatic arthritis. We'll discuss what psoriatic arthritis in a meanwhile, but remember, HLA-B27 it predisposes to psoriatic arthritis or pustular psoriasis. Okay, HLA-B27 it predisposes to two types of psoriasis. One is psoriatic arthritis and other is pustular psoriasis. Actually, these are complications of psoriasis. Remember, we will discuss this in a meanwhile, but remember this. These are actually complications of psoriasis. Okay, this is about predisposing factor. Then moving to types. One is the first one we have is psoriasis vulgaris. Psoriasis vulgaris. In this, as I told you, the lesions are erythematous plaques with silvery white scales present on especially extensor surfaces. Extensor surfaces. The sites mainly involve knee, elbow, back, and even scalp involvement will also be there. Scalp, palm, and even sole also. Okay, in all these sites we'll see psoriasis vulgaris. And the second type is, actually this is the main type, and other types are, the second one is scalp psoriasis. Scalp psoriasis. Here only scalp will be involved. Only scalp will be involved. Here in psoriasis vulgaris, knee, elbow, back, scalp, palm and soles are involved, but whereas in scalp psoriasis only scalp will be involved. And third one is palmoplantar psoriasis. Palmoplantar psoriasis. Here palms and soles will be involved. And fourth one is gut gutted psoriasis. Gutted psoriasis. In gutted psoriasis, what happens is it's especially happens in children, especially in children. Here this psoriasis will occur after upper respiratory tract infection. After upper respiratory tract infection, this gutted psoriasis will happen. Okay, so actually this question has been asked in entrance exams. So the question was, the child suffered from upper respiratory tract infection and he actually recovered from that infection. After that he developed some lesions over chest, uh, and trunk. And what is the diagnosis? The diagnosis is gutted psoriasis. Okay, and one more is, fifth one is rheumatoid psoriasis. Rheumatoid psoriasis. In rheumatoid psoriasis, what happens is the scales are very adherent to each other. In rheumatoid psoriasis, the scales are strictly adherent to each other. So scales are adherent to each other very strictly, very adherent to each other very strongly. So this gives appearance like this, like conical appearance. Conical scales will be seen, like this appearance will be seen because they are adherent to each other. Okay, then moving to, these are the types. Then moving to clinical features. Clinical features. Here we have to know certain tests and signs. Especially the first test is Grattage test. Grattage test. Let us see what is this test. Grattage test. So suppose this is lesion, right? This is lesion and this is covered by scales, right? What we do in this test is we'll take a slide. And using this slide we'll try to remove the scales. We'll try to remove the scales. As we go on removing scales, the number of scales that are coming will increase as we remove. Okay, the number of scales coming will increase. So this test is called Grattage test. Okay, the number of scales will increase as we go on removing the scales with the help of slide. Okay, this is about Grattage test. And one more test is palm candle grease sign. Candle grease sign. In candle grease sign, what we do here is, in Grattage test what we did is we'll try to remove the scales with the help of slide. Okay, right? So here also we'll go on removing the scales. The last layer of scales that are adherent to the skin. The last layer of scales that are adherent to skin will come like wax, like a dried wax. Okay, if you remove a dried wax on a surface, how it comes as a whole, wax will come as a whole, right? So similarly these scales will come as a whole. The last layer that is adherent to the skin will come as a whole, as a entire body. Okay, this is about candle grease sign. And third sign is third is, you see, if we remove the last scale, then we'll see the surface of skin, right? In the surface of skin, what we see is some, we'll see some petechiae, some bleeding sites. Okay, we'll see some petechiae. This petechiae are, we have given separate name for that. Let me tell you, this sign is called Aspid's sign. Okay, this sign is called Aspid's sign. Here what we did is, we removed the entire scales, right, with the help of slide. So at the last we'll see the surface of skin, right? On the surface we'll see petechiae like this, small pinpoint bleeding sites. Pinpoint bleeding sites will be there. Bleeding sites, this is called Aspis sign. Remember, this is A. Okay, so there are three important signs: Gratestes, candle grease sign, Aspis sign. Okay, this is about the signs. Then we'll see the clinical features now. First we'll see histology. In histology what we do is, so I told you there is proliferation of keratinocytes, right? Keratinocytes, these keratinocytes, they retain nucleus. This is called parakeratosis. This retention of nucleus in keratinocytes, that means the newly formed keratinocytes, is called parakeratosis. Okay, the second is, there will be absence of stratum corneum. Okay, stratum corneum will not be there. Then one more is acanthosis. Acanthosis means increased thickness of stratum spinosum. This thickness is due to, as I told you, the cells will separate because they are not perfectly adherent to each other. Okay, so this results in increased thickness of stratum spinosum. And dermal vessels will be dilated. As it is inflammatory condition, definitely there will be increase in dilation of dermal vessels will be dilated. And one more is, this is skin, right? So this, there is increase in the papillae like this. So due to this increase or enlargement of papillae, there will be thinning of the surface above the papillae. Okay, the part above the papillae will get thickened. So this is called suprapapillary thickening. Suprapapillary thinning. Suprapapillary thinning. These are the, and one more sign is Munro's microabscesses. The reason is, you see, this is skin, right? What happens is, there is infiltration by neutrophils. So these neutrophils will result in formation of microabscesses. These are called Munro's microabscesses. micro abscesses. These are the signs or the histology part of psoriasis. Now we'll see the complications of psoriasis. Complications of psoriasis. In this lecture, we'll discuss about complicated psoriasis and complications of psoriasis. In the last lecture, we discussed about how psoriasis occurs, what are the signs of psoriasis, what are the clinical features of psoriasis. In this lecture, we'll discuss about complicated psoriasis and complications of psoriasis as well. Okay, first is complicated psoriasis. Complicated psoriasis. These complicated psoriasis they occur after withdrawal of usage of systemic steroids. Okay, after withdrawal of systemic corticosteroids. Sorry, systemic steroids. After withdrawal of systemic steroids, this complicated psoriasis will occur. They are mainly two. One is pustular psoriasis and erythrodermic psoriasis. One is pustular psoriasis. Second one is erythrodermic psoriasis. Erythrodermic psoriasis. Let us see what are this pustular psoriasis and erythrodermic psoriasis. First one is pustular psoriasis. In pustular psoriasis, we will see multiple sterile pustules. We will see multiple sterile pustules. They are sterile because there is no infection. We do not find any infecting organisms, and these are seen on palm and soles. Okay, we'll see palm and soles. And if the pustular psoriasis is generalized, then it is called Van Zumbu's disease. Van Zumbu's disease. Usually they are present on palms and soles, but if the condition is generalized, then it is called Van Zumbu's disease. If this pustular psoriasis takes place in pregnancy, if it happens in pregnancy, then it is called impetigo epitiformis. Then it is called impetigo epitiformis. Epitiformis. So what in pustular psoriasis? This is a complicated psoriasis. It mainly occurs due to withdrawal of systemic steroids. In this, what happens is there will be multiple sterile pustules, especially on palms and soles. If this condition is generalized, then it is called Van Zumbu's disease. If it happens in pregnancy, then it is called impetigo epitiformis. Okay. Then moving to second complicated psoriasis, that is erythrodermic psoriasis. Erythrodermic psoriasis. In erythrodermic psoriasis, there will be inflamed or red lesions involving whole skin. There will be inflamed or red lesions over all over skin, all over. Okay, that means the whole skin appears red. Okay, this is called erythrodermic psoriasis. As I told you, both erythrodermic psoriasis and pustular psoriasis, they occur as a complication of withdrawal of systemic steroids. Okay, this is about erythrodermic psoriasis. And second is complications of psoriasis. Complications of psoriasis. In complications psoriasis, we have psoriatic arthritis. Psoriatic arthritis. This psoriatic arthritis can be classic. In classic type, the joint that is involved is distal interphalangeal joint. Interphalangeal joint will be involved. In asymmetrical oligoarticular type will also be there. Okay, asymmetrical oligoarticular type will also be there. This is the most common type. Okay, asymmetric oligoarticular type. Third type is symmetrical polyarticular type. Symmetrical polyarticular type. Okay, in complications of psoriasis, we have the first is psoriatic arthritis. In psoriatic arthritis, we have mainly three types. One is classical type, other one is asymmetric oligoarticular type, and third is symmetric polyarticular type. In classic type, distal interphalangeal joint will be involved, and second is asymmetric oligoarticular type. This is the most common type. Okay, this is about psoriatic articular type. Then moving to one more complication, that is arthritis multans. in in psoriatic arthritis also there will be arthritis multans also. I forgot to tell you, even arthritis multans is also type. Okay, there's not three types, even there is arthritis multans will also be there, and one more type is also there, in which as exoskeleton or axial skeleton will be involved. Exoskeleton will be involved. Okay, so basically psoriatic arthritis is five types. Okay, I told you three types, but it actually five types. Classic type, asymmetric oligoarticular type, symmetric polyarticular type, arthritis arthritis multilens, and other type in which there is involvement of axoskeleton or exoskeleton. This is about complications of psoriasis. So this is the complication. In the next video we'll discuss about the treatment. Let us discuss about treatment of psoriasis. Treatment of psoriasis. The treatment of psoriasis, it includes topical, systemic, and phototherapy. In the treatment of psoriasis, one thing we have to remember here is we should not use systemic steroids. Usually in any inflammatory disease, what we do is we'll try to suppress inflammation by giving steroids, right? But in psoriasis, even though it is inflammatory condition, we don't advise the patient to take systemic steroids, because after withdrawal of steroids, there will be rebound psoriasis. Okay, due to rebound psoriasis, we don't give systemic steroids in psoriasis, but we can give topical steroids. Okay, the topical, as I told you, we can give topical steroids. So the first we discuss is topical. In topical, the drugs we have here is corticosteroids. Corticosteroids. Second is we'll give keratolytic agents. Keratolytic agents. This includes salicylic acid, coal tar, and coal tar. Okay, these two are the keratolytic agents. Third one is we'll also give vitamin D analogs. The examples of vitamin D analogs are calcitriol, and one more is calcipotriol. And we'll also give topical retinoids. The drug is tazarotene. So these are the topical agents. The topical agents are corticosteroids and keratolytic agents like salicylic acid or coal tar, and vitamin D analogs like calcitriol, calcipotriol, and retinoids like tazarotene. Okay, these are the topical agents. Then moving to systemic agents. In systemic agents, we'll have methotrexate, one more is, you have to remember one thing. We have to remember here is methotrexate. It is hepatotoxic. And it is also teratogenic. So we should not give this drug in hepatic patients, and we should not administer the drug in pregnancy. And second drug we have here is cyclosporine. This cyclosporine, it is nephrotoxic. And it also causes hypertension. So we should not give in those patients. And one more is it also causes hypertrichosis. Okay. And one more drug we have here is acitretin. It is a systemic retinoid. Acitretin, it is a systemic retinoid, and it is also teratogenic, and it causes dyslipidemia. Okay, these are the systemic agents. The systemic agent we have is methotrexate, cyclosporine, and acitretin. Okay, acitretin, it is a systemic retinoid. And the last is phototherapy. Phototherapy is very important in this patient. The phototherapy include Puvasol. One more is narrowband ultraviolet B. Target phototherapy. Phototherapy. So here PUA means we'll expose the patient to ultraviolet radiation A. Will expose to ultraviolet radiation A. Okay, in PUA sol we'll expose the patient to sunlight. Will expose the patient to sunlight. In narrow spectrum, narrow band ultraviolet B, will expose the patient to ultraviolet B rays. Even in target phototherapy also will expose to ultraviolet radiation. But the difference in target phototherapy is will expose only the lesions. Only the lesions are exposed. But whereas in other types, PUA, PUASOL and this NBU, UVB, the whole body is exposed. Okay, and there are these phototherapy can be used for other diseases, other skin diseases also. But there are certain two specific phototherapies for psoriasis. They are, one is Ingram regimen, Ingram regimen, and one more is Gickerman regimen, Gickerman regimen. These two are the phototherapy that are especially used for psoriasis. Let us see what this special phototherapy are. One is Ingram regimen. First one is Ingram regimen, right? In Ingram regimen, what we do is we'll administer diethranol to the patient. We'll apply diethranol on the lesions. We'll apply diethranol. After applying this, we'll expose to the light. Okay, this is what we do in Ingram regimen. And the second one is Gickerman regimen, right? In Gickerman regimen, what we do is instead of diethranol we apply coal tar. In Gickerman regimen, what we do is we'll apply coal tar on the lesions, and after that we'll expose to the light. Okay, this is what we do in Gickerman regimen. Apart from phototherapy, there are certain biological agents that are used in treating this, that are used in treatment of psoriasis. Because you see, this is the inflammatory condition, right? So as it is inflammatory conditions, we have to use some biological agent. These biological agents will be helpful because they inhibit this chronic condition, chronic inflammation. Okay, the important biological agents that we use are monoclonal antibodies. Monoclonal antibodies. Okay, these are biological agents. Here we use monoclonal antibodies. The first group that we use is tumor necrosis factor alpha inhibitors. Tumor necrosis factor alpha inhibitors. In this we have infliximab. Second one is adalimumab. Third is etanercept. These are tumor necrosis factor alpha inhibitors. And fourth drug is efalizumab. This efalizumab, it binds to CD11. this CD11 is a T cell marker, okay. And one more is itolizumab. It binds to CD6, okay. This is alifacept. It binds to CD2. All this itolizumab, alifacept, these three are T cell inhibitors. They are T cell inhibitors, okay. And three more drugs are there. They are apremilast. The three drugs are, first one is apremilast. It is prostaglandin E4 inhibitor. And one more is secukinumab. It is anti-interleukin 17A it is anti-interleukin 17A. And one more is utsecumab. It is anti-interleukin 12 or 23, okay. It is anti-interleukin 12 or 23. These are the important drugs. And then moving to the drug of choice for various psoriasis. In psoriatic arthritis, which is a complication of psoriatic arthritis, the drug of choice is methotrexate. In erythrodermic psoriasis, the drug of choice is here also it is methotrexate. In pustular psoriasis, the drug of choice is acetatin. We can also use methotrexate in pustular psoriasis, but the preferred one is acetatin. Then impetigo epatiformis. In impetigo epatiformis, it takes place in pregnancy, right? It occurs in pregnancy. So in pregnancy we should not use methotrexate. So the drug of choice here is systemic corticosteroids. Because they are safe in pregnancy. We can also use cyclosporin also. Because these two are relatively safe, the corticosteroids and cyclosporin, when compared to other drugs. Okay, this is the treatment of psoriasis. Thank you for watching.